Okay, one sulfur colloid.
Tech goes to the stomach.
Well, if it's labeled with red blood cells, it shouldn't go to the stomach unless you've got a bleed in the stomach.
If they had the red blood cells, don't you have to, well, if you make a kit, you're taking out the blood, mixing it with sulfur colloid, or you're mixing it with something so it attaches to tech, and you inject the blood.
Okay, well, let's go back here for a minute. Okay.
How is it? Technetium.
Okay, this is actually technetium red blood cells. The reason why is because you see blood vessels. Okay, these are all arteries that you see here. Okay, now the reason why it's not sulfur colloid is because sulfur colloid would be picked up by the liver, the spleen, and the bone marrow, and you wouldn't see anything there at all. I mean, you would see a liver, you would see a spleen, you would see bone marrow. We normally only use sulfur colloid for what we call active bleeding. And this is an important concept, okay? Because on your board exams, they're going to ask you, what is the recommended radiopharmaceutical for an active bleed? Sulfur colloid would be the correct answer. Labeled red blood cells are what we use for what they call intermediate or intermittent bleeding, okay? So normally you take technetium, and what's in the kit is what they call tin chloride. Basically, you're taking tin chloride, which is the reducing agent that we use to allow technetium to label other kits. Remember that term, tin chloride? SnCl2? Okay, tin chloride is what allows technetium to label to DTPA, MAA, MDP. Every radiopharmaceutical that we use, except sulfur colloid, requires that technetium be changed from its valence of +7 down to a valence of +3 or 4. That's what tin chloride does, is it changes the valence so that it will attach. Technetium is a metal. Usually the only way you get metal to attach to organic molecules is when you drive your car into a wall and your steering wheel goes through your head. That's the way metal fuses to organic materials. So, as I said, so that's what tin chloride does. What they did, and we actually did research on this. Our hospital was doing the first kits that came out from Brookhaven National Laboratory. We would take the red blood cells, we mix it with the tin chloride, we add the technetium to it. Now we used to centrifuge the blood down and wash off any unlabeled technesium that was in the plasma. Okay, so sometimes you may or may not do,
So when you centrifuge it, did the tech get out the plasma, or did it continuously be part of the blood?
No, well, what will happen is you got some tech that's attached to the plasma proteins, and so when you centrifuge it, you basically wash the cells.
Right.
So you get rid of the liquid part that has technetium in it. You do that a couple of times, and pretty much you got mostly just tagged red blood cells. So that's what they do it for. Anything that's still floating around in the plasma is going to create a background issue. So you see like all this garbage in the background? Yeah, if you can reduce that, you get a much better picture. Okay? So usually the better the tagging, the less background garbage you're dealing with. Okay? So like in this case here, what you're looking for over a period of time. Now most people do a flow study, and then you'll do pictures. I know most hospitals like every 15 minutes for the first hour, or every 5 minutes for the first hour. It depends if you have look here for, then if nothing shows up after an hour, then maybe you do an hour and a half, and then 2 hours. And usually most places probably go for about 2 hours. And then if there's still no bleeding, they bring the patient back in 24 hours and do a 24-hour scan. And then if there was any bleeding, you'll see it in the abdomen. So I like to say, I don't know if that's what you guys, protocols differ, but okay. But this is the physical leakage from a luminal compartment. Okay, GI bleeding. And then the one that you guys are just dying for, or maybe just dying, is going to be active transport. Oh, wait a minute. Never mind, metabolism. All of your FDG stuff, that's metabolism. So, because we're using radioactive sugar, we're actually able to look at carbohydrate metabolism, and this is a good example of it here. Okay, if you inject FDG, brain lights up. And remember, the heart usually prefers fatty acids as its main source of energy. It only uses glucose when it can't get enough fatty acids, or we give the patient insulin. Sometimes we'll do that. But basically what you see with FDG